Top Med Talk.
Hello, welcome to Top Med Talk Down Under. I'm Andy Cumpstey and I'm here again with my co-host Kate Leslie in the beautiful Cairns, sandwiched between the Great Barrier Reef and the oldest rainforest in the world, at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine's annual scientific meeting. And it's been a fantastic meeting so far, hasn't it, Kate?
Oh, it certainly has. And I think last night was a bit of a highlight. They called it a tropical soiree, which sounds very smart, but it was in a beautiful tropical garden that had different pavilions in it with art, and there was food and drink, and then the one at the back was a fantastic dance party. And the ANZCA annual scientific meeting is actually well known globally for its dance party, where all of the delegates, or not all of them, a lot of them, let it out all, first time in the year for a good dance. So that was fun.
And not just the delegates. I think, the plenary speakers were there, the events team were there. It's a really great occasion where everybody at the meeting is just mixing and mingling with each other, and a really good, pretty unique feeling about it, I think.
And I think I commented to one of the international visitors that this is exactly what collegiality and fellowship are, and it's this sort of the secret sauce really to why our research efforts are so successful, which sort of segues into the terrific guests that we've got now, Andy.
We've got some brilliant guests with us, so it's a pleasure to introduce Dr. Chris Bain, Dr. Luke Perry. Chris, do you want to go first? Tell us a bit about your current role and where you're working.
I'm a cardiac anaesthesiologist, and I work at the Alfred Hospital in Melbourne and in private practice in Melbourne.
Fantastic.
But I spend as much time as I possibly can trying to do research as well, juggling all the other bits and pieces of life, research, medicine, parenthood.
Excellent. We'll pick up a few of those topics in a second. And then Luke, what about yourself? Where are you working at the moment?
So I'm an anaesthetics registrar at Monash Health in Victoria, and I'm also the head of research at the Victorian Heart Hospital and a father of 2 young boys.
Brilliant. So, Chris, I'm going to come to you first because we both share a passion about translational research, and we were talking about this the other night at the conference. But for our listeners at home, what is translational research? What does it mean?
So translational research is really about trying to find or discover things about the body, might be signals, markers, biomarkers, processes that are occurring that may not necessarily be immediately obvious, and then seeing how they impact on people's recovery, for example, after surgery, and then trying to understand a bit more about the differences between the way people recover, and then taking that information to think about how we might implement changes in the way we look after patients having surgery so that we can improve their outcomes. And that might obviously be signals that result in processes that go to drug discovery, or it might be that we learn how to use the medications and therapies that we have in different ways in different people. So in other words, not treating everybody the same way, but personalising care in a different way by looking at these markers that define people as being different, because we know that everybody's journey is different, but we don't necessarily know how or why it is. And this concept is about discovering those things and using it to translate that information, to translate and transform the way we look after patients in the perioperative period.
Excellent. You mentioned personalisation or personalising medicine. We hear that all of the time, don't we? As that's the direction of travel, but it's quite hard to do. How do we make this? How do we make that leap forwards? How do we start personalising our care, do you think?
Well, it is hard because you've got to look really hard at what happens to patients when they have surgery, and find out the differences about them. And like anything, it's actually, it's a very different principle to, like, for example, a large clinical trial where you'll have a test in mind and you'll apply it to a large group of people and look for a difference. This is about saying, despite the fact that there is the response to that drug in the trial setting, in fact, within that trial there's a lot of differences. So it's very hard to find those differences, that source of heterogeneity.
So you're interested in what could be broadly defined as, genetics. We've got genes and their DNA, and we've got RNA, and then we've got ribosomes and transcriptionomics and all that. Can you just give our listeners a very brief primer on all of that in a much more scientific way than I just did?
Absolutely. So my interest is in this notion that that our response to the experience of trauma is also not only due to the process of trauma and healing and things like that, but underneath and underlying it all is a genomic response. Our body's genome responds to that. And the genome is made up of all these different processes. It's not only just your DNA, so the A's and B's and C's and D's of DNA variation, but also the expression of genes and how that expression changes. In other words, that's the RNA and how those RNA levels go up and down. And that's a reflection of how your DNA is expressing it, how your DNA is responding to surgery. And then obviously there's the proteins that result from gene expression and how they change. So that's another source of marker in our systems that you can look at to try and understand the response.
So how does trauma turn our genes on and off? We've got 2 genes for each, there's one on each chromosome, isn't there? How does trauma turn off one or both of the genes that are important for our recovery in any particular situation?
Fantastic question. So when people have trauma, whether it be a process like a traumatic event, an injury, or of course major surgery, there's an immediate response. In fact, it's immediate. It starts the second the surgery starts, and it's this process known really. It's essentially what I call a host response, but it involves inflammation and your immune system, and all the cells will be attracted to triggers that are released the moment the injury occurs, and they whiz to the site where the injury occurs, and they detect all these signals of injury, and that causes their genomes to fire up and start expressing different genes. And it happens instantly. So essentially what I'm saying is that the process of healing and recovery from a major operation or indeed a major traumatic event like falling off your bike and breaking your leg is immediate. It starts within seconds. And everybody's experience of that, not only in terms of how they feel and pain and things, is different, but also it's different at the genomic level as well.
And so I think I got from your talk that it's the balance between inflammation and immune response or immune suppression that's important. And you told us some information about how the administration of a single dose of dexamethasone in the PADDY study influenced those things. And I don't think I completely followed the first time. So, and Andy did for sure. So can you explain that again?
Yeah, absolutely. So I've been saying for years that what we increasingly now know is that people's responses differ, and some people have really big responses to injury, and others have smaller responses, and there's a lot of reasons for that. Obviously, there's the factors like the size of your surgery and duration of your surgery and things like that, but at the end of the day, there are also background differences. We are also really interested in this notion of using drugs like a steroid, particularly dexamethasone, to try and change that response in people who are having a big response as opposed to the small response, because we think and we know and we've measured that the big ones are harmful.
And people will remember in the pandemic that there's some people got a big immune response and were saved by dexamethasone.
Correct. And the really interesting question is trying to work out which patients need the dexamethasone from the ones that don't, because we're not looking at just we need to have, we're looking for the marker that says they're on the way to really harmful levels of inflammation and a body's response to injury, and a dose of dexamethasone might do them more benefit than harm, versus the ones where they don't have much of a response. You give them the dexamethasone and they don't benefit from it at all.
It's really exciting work, Chris, and a fantastic presentation that you gave. And I think, just to drill that down one more level for the listeners at home. So we're looking for differences in our treatment response. So there's some responders to dexamethasone, some non-responders to dexamethasone. But in each of those categories, you're going to get good responders and less good responders. There's a whole spectrum there. But there's also there's different starting points. So, patient X and patient Y are not starting in the same position either. They may have a different genetic susceptibility and with a response from that, but also there's then our other anaesthetic treatments coming in where if we give them an intravenous anaesthetic or a volatile anaesthetic, that might... So there's so many complex factors in this, isn't it? It's really difficult work to do.
Yes, it's really difficult. You have to have an open mind about it all and just wait for the results to come at you.
Yeah.
You can't really know what you're going to see until you do it. But it's interesting to do, and it's all embedded in this notion that everybody's different. It's not that one treatment fits all, and recognising if you give everybody the same treatment, some people benefit, and that's the thing you want to see, but some people don't. And we've got to work out how to try and tailor those treatments that we use, whether it be a steroid like a dexamethasone, or an antibiotic, or a total intravenous anaesthetic, or different types of inhaled anaesthesia, or different analgesic approaches to their response.
It's great work. I love it, and you explain it really well. And you can tell when you're speaking about it that you're really passionate about it. It's fantastic.
Yeah, it's an interesting job.
It's always good to research something that's of interest to the people who are listening. And I think Luke Perry, our next guest, has chosen to attack a topic that's been as controversial as anything in anaesthesia for decades. And that is maybe the only thing that's more controversial is whether regional anaesthesia has any benefits over general anaesthesia. But the question at hand is, do patients having coronary artery bypass surgery or all types of heart surgery benefit from a pulmonary artery catheter? So, Luke, how did you decide to look into that particular topic?
Thanks, Kate. So in 2020, when I was a crit care resident, I got lucky enough to insert a pulmonary artery catheter in theatre, and I followed up with our patient the next day in ICU, and he was looking pretty well, extubated, eating a sandwich, and the intensivists were standing around looking at the cardiac index of 2 and debating which inotrope they should start. I thought, that's a bit funny and discordant, and I went and did a literature review and found out that no one had ever done a trial. People had published obituaries about the pulmonary artery catheter and moratoriums, and there have been about 100 editorials, but never a randomised trial. And that's
Why
how
do
it all
you
started.
think there had not been a randomised trial?
One of the difficulties with research in cardiac anaesthesia is that there are 3 craft groups intimately involved in patient care. You've got cardiac surgeons, intensivists, and cardiac anaesthetists. And so any trial that gets done has to have the support of all 3. And people are very passionate about pulmonary artery catheters, and that's reflected in the large degree of variation in practice nationally and internationally. It's one of the reasons we chose to do a pilot and feasibility trial for Puma, because we wanted to make sure that politically that this would fly.
Indeed. So how did you go about setting up the pilot trial?
So from conception, we did some retrospective work using database studies to further explore the hypotheses, and we did a systematic review. And from there, we built a team, with including people from all 3 of those disciplines I just mentioned. And then we approached the ANZCA Foundation and applied for an ANZCA project grant, and we were lucky enough to be successful. We also got funding from the Heart Foundation through a Vanguard grant, and ended up getting endorsement from the ANZCA Clinical Trial Network. And from there, that sort of preparatory work took about 18 months, and from there we were able to launch the Puma pilot last year in July, and that was conducted at 3 sites in Victoria, 150 patient trial, and we finished recruitment in just 6 months.
Unbelievable.
Fantastic.
It's so good. Pilot and feasibility trials are one of the most misunderstood trial types. As a journal editor, I often get trials that are actually just small randomised trials that people are trying to pass off as a pilot study. So it's really important to have feasibility outcomes. So which feasibility outcome, before we get the grand reveal of the results, or maybe you can tell us what were the feasibility results of the pilot trial?
So the Puma pilot exceeded all feasibility targets for about 5 feasibility outcomes. We selected a primary feasibility outcome on the basis of what we would be most concerned would represent a threat to the feasibility of Puma 2, which is the definitive trial. And we considered that the biggest threat would be treatment crossover from patients who were randomised to not receive a pulmonary artery catheter, where the clinicians are anxious in the event of a deteriorating patient and would insert a pulmonary artery catheter. So that was our primary feasibility endpoint. And then we also selected the standard recruitment eligibility rate, recruitment proportion and rate, complete case repeat. complete case report form rate and an estimate of resource expenditure.
Nice. And for the information of our listeners, I assume that every patient had transesophageal echocardiography?
Yeah, that's the standard of care in all of our centres, and we excluded patients who had a contraindication to transesophageal echo. We only had one patient that was excluded due to a previous esophageal surgery.
Terrific. And were there any signals in the efficacy outcomes for the trial?
So no, we didn't see any signals, and we were purposeful with the pilot that it should be a pure pilot and feasibility trial. So we didn't put too much credit into those analyses. We did for pilot purposes. So can we collect that data? Are the outcomes feasible to collect? We did collect a lot of mechanistic and clinical outcomes, and so for things like days alive and at home, quality of life, length of ICU stay, and time spent in postoperative organ dysfunction, we saw absolutely no difference. There was a non-significant signal with acute kidney injury, but we really were deliberate not to go fishing for type 1 error with this.
Are you going to use a non-inferiority approach when you do the main trial?
Great question. We debated this a lot internally with the senior trialists that are involved, and we are deciding to do a non-inferiority design, and our statisticians have assured us that we can do dual non-inferiority and superiority testing.
So for our listeners at home, Luke, can you just maybe summarise what some of the key differences are with those designs and why they matter for people who might be reading the trial later?
Sure. So it all depends about what your hypothesis is and what you want to test. Our hypothesis after the pilot trial and after exploring the observational literature is that there's probably no significant or clinically significant difference in outcomes like days alive and at home between the two devices. And so a non-inferiority design is appropriate because we can assert that pulmonary artery catheter-free management is not significantly worse than management with a pulmonary artery catheter. And on that basis, and in response to surveys of clinicians and focus groups, there is appetite for de-adoption of pulmonary artery catheters if a non-inferiority trial were to show non-inferiority.
So we've got a senior cardiac anaesthesiologist sitting next to us in the podcast. Are you clutching the edge of your chair thinking, I can't live without my PA catheter?
No, not at all. Not at all.
Do you use them in every case?
Most, actually, but that is a reflection more than anything of the type of practice and the place that I practice, and it's exactly as Luke says, the interaction of the surgeon, the anaesthetic team, and the intensive care areas, which they're all very used to. But, you know, if I was working in other parts of Australia or New Zealand, I know full well that I probably wouldn't be using them at all. So I'm very open-minded and interested to know if you are able to show that it's or demonstrate non-inferiority.
And one of the things we'll never be able to power a trial around is the other rare but catastrophic complications with pulmonary artery catheters. So around 1 in 3,000 cases, you do something like rupture the pulmonary artery and cause a fatal endobronchial hemorrhage. And so one of the things we can say is that with non-inferiority, we can at least de-adopt and avoid those. And that's why we've selected the non-inferiority design.
Yeah, no, I reckon that sounds like the way to go. Absolutely.
I'll put you on the spot, Chris. What information do you use on the PA catheter that you're not getting from the echo?
So for most cases, there isn't a lot of information I can't understand or figure out. Sometimes in some patients, and it may or may not be represented in the group that you end up analysing, the output, the heart function demonstrates really low levels of function either before or during or in the first part after the open heart surgery phase. And it is another piece of information that gets put together when you're making difficult decisions about what to try next. It's not the whole story, it's about putting everything together. And in that situation, it provides information that can be quite helpful. But that's in my experience, and I've been using that device for a long time, combined with echocardiography and also the really experienced surgeon. So there's a whole lot of eyes looking at all of the information. But that's probably the one time when I do find it can be quite helpful.
Andy, you're an intensivist. in Southampton. What's your view of the utility of PA catheters in cardiac surgery?
So I'm a general intensivist, is the first thing to say, but we don't use PA catheters at all in the general ICU, and I don't remember our cardiac anaesthetists using PA catheters frequently at all either. And I say I should disclaim that I'm not a cardiac anaesthetist in the UK, and we have a separate cardiac intensive care team in Southampton, but it's definitely not common practice that I was familiar with going through my training.
No.
So this is, what Luke knows is called equipoise. Yeah. Can you talk a bit about your literature review on the subject of equipoise in the use of PA catheters?
Of course. I'll just mention general ICU patients. Pulmonary artery catheters were really popular in the 80s, 90s and early noughties. Large international multi-centre trials got published, support FACT Pacman, in patient groups like sepsis, ARDS, etc. They showed worse or no difference in outcome. And then there was a moratorium called for in their use, and they were de-adopted over 95%. So in cardiac surgery, we have ongoing equipoise. It's evidenced by a study we did in Australia showing 20 to 1-fold in variation in practice between state lines. So colleagues in Queensland and South Australia use them in about 4 to 5% of cases, whereas in Victoria we use them in essentially 100% of cases. Moreover, our observational research is also varied. So we did a systematic review showing an association with increased operative mortality, higher intensity perioperative treatments, and also complications from about 12 studies involving 25,000 patients. And then after that got published, the Koreans published a national data set analysis with 60,000 patients showing a significant survival benefit with pulmonary artery catheters. And so I don't think anyone can look at that and know for sure whether or not pulmonary artery catheters are helping or harming patients, which is why we need a randomised trial.
And in those retrospective studies, if you do them in a situation where everyone gets the result will depend upon the proportion of the group that's getting or not getting a PA catheter and who's making the decision about whether to put one in, because you might put them in fit people or you might put them in sick people or...
That's right.
Yeah.
And the biggest threat to validity of those studies is unmeasured confounding. And so patients who received a pulmonary artery catheter were likely sicker at baseline, and not all of those markers of sickness can be reflected in administrative data sets, for example. And so despite all of the adjustments and statistical analyses and acrobatics you do, without a randomised trial we won't have a good answer.
So what's the process now for setting up your multi-centre trial? How many patients and where are you going to?
So Puma 2 will be a Bayesian adaptive trial, and we're going to include 2,000 patients at 25 sites in Australia, New Zealand and the US. It'll be conducted over about 4 years. It's going to include just low and moderate risk patients, so there's some safety nets, and it's going to be totally pragmatic, meaning there's no goal-directed treatment algorithm that's enforced, so that it improves compliance and reflects real-world practice.
What's going to be adaptive about it, Luke? What does that mean?
Yeah, so adaptive can mean multiple things in the context of a randomised trial. Our trial will be adaptive in the sense that we're going to be conducting interim analyses and recalibrating the final sample size to ensure we don't have a near miss for finding out our answer. It's also going to be adaptive in the sense that we will be having an optional women-only extension phase to ensure equitable recruitment. In cardiac surgery, only around a third of our patients are women, but only 15% of patients in randomised trials are women. And so the Roma Women trial, which we're running, is just for women, and we're going to be modelling off of that with Puma 2.
And women often do worse after cardiac surgery.
That's right, they have worse outcomes.
My understanding of that is that it's a complex thing, that it could be that the primary risk factors are under-recognised and under-treated in women, and therefore they can progress to surgical coronary artery disease quicker or in undetected or untreated. They may have different access to cardiac surgery through various, systemic and individual biases. And then there's practical. Their coronary arteries are smaller, aren't they?
That's exactly right. That's one of the reasons why they're doing this multi-arterial grafting versus single arterial grafting trial just for women, is because their anatomical targets are just much smaller.
So Luke, can you tell us a bit about this interesting trial about women and cardiac surgery?
So it's called Roma Women. It's a trial led by Mario Gaudino from Cornell. It's comparing multi-arterial to single arterial grafting in women having coronary artery bypass grafting. It's nearly finished, so we'll have some results in the next few years. and it's the world's first trial in cardiac surgery just for women. It follows on from the Roma trial, which was in men and women, which had inequitable recruitment, and so they're essentially extending it to include just women on the basis of several hypotheses around why women might benefit more from multi-arterial grafting strategy.
Fantastic.
Brilliant.
So getting back to Puma 2, are you going to use jungle animal acronyms for all of your studies?
That's a work in progress. We're strongly considering it.
The Global Surge Group, which is located in the UK, isn't it, use jungle animals. And I'm on their penguin DSMB, which is not a jungle animal and which is about a study in Africa. And every time we have a meeting, I say, can you remind me if there are any penguins in Africa? And apparently there's a penguin colony on the southern tip of Africa in South Africa.
There you go.
It's a great trial penguin. It's about if you have chlorhexidine mouthwash, whether that reduces the risk of post-operative pulmonary complications.
Wow, that's
because
really
it
cool.
sterilises the mouth and pharyngeal flora, and when you aspirate bits of saliva and so forth, that's what, and you've got a bit of atelectasis, that's what leads to post-operative pulmonary complications. There's so many great studies out there, and I wish I was you, Luke, closer to the start of my anaesthesia research career, because there's still, it's amazing that question about PA catheters has not been answered, and it took someone with a bit of youthful vigour to get it off the ground.
Well, I wanted to pick up on that point because we're very fortunate here. We've got, say, two different experiences in terms of clinical experience, a consultant and a resident, but you're both doing fantastic research work that I can see you're both really passionate about. How do you fit that in around your busy clinical schedules, and how would somebody else make that step into that space?
Yes, it's really a real challenge, and it just sneaks up on you quickly. You start off with an idea, and then you write a study, design a study, and next thing you know, you're doing a pilot study, and next thing you know, you're getting results, and next thing you know, you're presenting results and getting more money, next thing you know, you're spending more time on it. That is a challenge, especially when you're a clinician and you've got responsibilities to the institution you work with, and also a parent or busy with home life, doing all other things. Everybody's lives are full. And I don't have the answer to that question as a clinician researcher. You have to make tough decisions about what you want to do. That's really where I'm at the moment with it all.
And what about yourself, Luke? You've managed to fit this in around training and all the extra commitment to the exams that has and so on?
Not without challenge, but I really love research. It's added so much to my life over the years, and I just find a way. It adds so much.
Yeah, brilliant. Well, it's great to hear you both so passionate about what you're doing. Really looking forward to hearing all the results you've got coming out in the near future. And thank you for joining us on the podcast. As always, you can hear us on our app, on social media, or on our website. And if you do find us on social media, make sure you hit the thumbs up, give us a like. Every little one of those things helps. We're on Facebook, X, Blue Sky, and now YouTube. And we really need to thank our sponsors. So as always, without BD, GE and Solventum, we wouldn't be able to bring Top Med Talk to you free and open access around the world. Thanks both for your time. Look forward to hearing you next time.
Thanks so much.
Thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.